Oh, good morning, students. Today I'm going to tell you about borderline personality disorder. This disorder is a psychological condition marked by a prolonged disturbance of personality function, characterized by unusual variability and depth of moods. The disorder typically involves an unusual degree of instability, black and white thinking, or splitting. Often manifests itself in idealization of and devolution of episodes and chaotic and unstable interpersonal relationships. Issues with self-image, identity, behavior, as well as disturbance in the individual sense of self. In extreme cases, it even can lead to periods of disassociation. It's only recognized by the Diagnostic and Statistical Manual of Mental Disorders in individuals over age of 18. However, there's symptoms necessary to establish the disorder and can also be found in adolescents.
The primary symptoms of BPD are unstable interpersonal relationships, affective distress, marked impulsivity, and unstable self-image. Individuals with BPD tend to experience frequent, strong, and long-lasting states of aversive tension, often triggered by perceived rejection, being alone, or perceived failure. They may show liability between anger and anxiety, or between depression and anxiety and temperamental sensitive to emotive stimuli. The negative emotional stress specific to BPD fall into four categories: destructive or self-destructive feelings, extreme feelings in general, feelings of fragmentation or lack of identity, and feelings of victimization. Splitting in BPD includes a switch between idealizing and demonizing others. This, combined with mood disturbances, can undermine relationships with family, friends, and co-workers. Individuals with BPD can be very sensitive to the way others treat them, reacting strongly to perceived criticism and hurtfulness. Their feelings about others often shift from positive to negative, generally after a disappointment or perceived threat of losing someone. Self-image can also change rapidly from extremely positive to extremely negative. Impulsive behaviors are common, including alcohol or drug abuse, promiscuous and intense sexuality, gambling and recklessness in general. Evidence suggests that individuals with BPD, while being high in intimacy or novelty seeking, can be hyper alert to signs of rejection or devaluation, and tend toward insecure, avoidant, or ambivalent or fearfully preoccupied patterns in relationships. They tend to view the world as generally dangerous and malevolent.
More symptoms include suicidal thoughts and self-harming. The suicidal rate of people with borderline is really high. Self-injury are common, and the age of onset is usually from adolescence to young adulthood. Abuse is one of the triggers of BPD, and studies have shown that 35% of the people with this disease have it because of genetics. Medication is available, but it doesn't help significantly, and it doesn't heal the core of BPD. Sufferers may utilize mental health facilities, as 20% of patients in a psychiatric hospital suffer from borderline personality disorder. Fortunately, within 2 years after being diagnosed, about half of those suffer make good progress and achieve remission within 6 years. Many say they have good psychological well-being.
Since the feature of BPD include emotional instability, intense unstable interpersonal relationships, a need for relatedness, and a fear of rejection, there is much stigma associated with the disease. People with BPD often evoke intense emotions in those around them. Pejorative terms to describe persons with BPD, such as difficult, treatment-resistant, manipulative, demanding, and attention-seeking, are often used, and may become a self-fulfilling prophecy as the doctor's negative response triggers further self-destructive behavior. In psychoanalytic theory, the stigmatization may be thought to reflect the countertransference, which is when a therapist projects their own feelings to a client, as people with BPD are prone to use defensive mechanisms such as splitting and projective identification. Thus, the diagnosis often says more about the doctor's negative reaction to the patient than it does about the actual patient. As an expression of countertransference hate, Borderline explains away the breakdown in empathy between the therapist and the patient and becomes an institutional epithet in the guise of pseudo-scientific jargon.
This inadvertent countertransference can give rise to inevitably clinical response, including excessive use of medication, inappropriate monitoring, and punitive use of limit setting and interpretation. Many people say that the level borderline is unhelpful, stigmatizing, inaccurate, and doesn't describe the suffering. Thank you so much for joining me, and I will see you next time. Bye 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 bye!
All doctors report to the psychiatric ward. We have an escape in progress.